Hi, everyone. Hope you can all hear me okay. So spasticity is a really interesting topic. It's something that is very complex, and it's not only for brain injury, it happens in multiple different neurological injuries as well. So like Kadar said, I am the medical director of the brain injury program at Dodd, and I also do outpatient spasticity work as well. So I have no financial gains for any of this or any of the medications I'll be discussing. So really the main thing that I wanted to talk about was kind of defining spasticity, identifying some treatment options. There's some newer things that you'll be hearing about in the next session next week about functional electrical stim and some of the modalities that the therapists use. And we'll be talking about some of the serial casting and dynamic splinting as well during that session. And I'll be talking a little bit about some of the interventional things like botulinum toxin injections and baclofen, intrathecal baclofen therapies. So we're going to be pretty comprehensive. So today I'm really going to focus on some of the medical piece of it and kind of more definitions and understanding just the basic overview of what spasticity is. So really the main thing, this is the actual clinical definition. So if you read it in any medical textbook, it'll tell you this exact definition where it's a motor disorder characterized by velocity dependent increase in those tonic stretch reflexes. But it'll also, you have exaggerated tendon jerks, which is those reflexes. So when you go to the doctor and they check your reflexes in your elbows or in your knees, some of those can be hyper-reflexive and so it's an upper motor neuron syndrome, and we'll kind of talk a little bit about these stretch reflexes. But the main thing is velocity dependent. So I have a lot of patients that tell me, well, when I'm sitting, things are okay, but as soon as I start moving or transferring or some of my patients, they're fine even when they're walking, but as soon as they start jogging, the spasticity can kick in. So that, again, velocity, the quicker you move. And in spasticity, the muscles are always contracted. And so that's where when you have people with spasticity and you're worried about it, it's because their arm or their leg or their posture or their neck is in such a position that those muscles are constantly contracting and shortening. Over time, we get concerned about that because that stiffness and tightness in the muscles can interfere with some of the normal movement. It can also interfere with speech. People don't think about it, but you have lots of muscles in your face and you can have spasticity in your facial muscles as well that affect speech. And then it, of course, can affect your gait. So some of the symptoms that we talk about with spasticity, so increasing muscle tone. So I have a lot of people that'll ask me, well, is spasticity and tone the same thing? The answer is yes and no. So if we talk about people with normal tone, that means their muscle bulk, strength is normal. But then you can also have this increased tone, which is where you have tighter muscles. They feel a little bit firmer. They feel a little bit more difficult to move. And that's where we call it, they have increased tone, and not necessarily is it spasticity, because remember, it's not necessarily velocity dependent. But the overactive reflexes, like I talked about. So involuntary movements. So there are some types of spasticity that are like dystonic movements. If people are trying to go and pick something up, you try to pick up a glass and then your arm all of a sudden jerks, or you're trying to pick up your leg to put your shoe on and your leg will jerk. So you can have some of those dystonic spasms. And then you can have what we call myoclonus, which is if we do certain reflexes, like at the ankle, and people will say, my foot is always bouncing, or my leg's bouncing when I move it, that's clonus. People can have clonus when you do the stretch reflexes, but you can also get clonus when you are transferring or sitting, or people can have an action myoclonus anytime they try to do a movement, and that can happen more with our patients with anoxic brain injury. So pain is a big part of spasticity, because if you think about it, when your muscles are constantly contracted, or you have that kind of high tone, or they're kind of in that weird position because of the muscle spasms, it can create pain. The muscle spasms can also create pain from a nerve standpoint too. So people will talk about pins and needles or electric shock pain, because when those muscles are contracting, could they be pinching a nerve as well? So decreased functional abilities and delayed motor development. So when we talk about delayed motor development, we talk about our children with neuromuscular disorders like cerebral palsy. But when we talk about decreased functional abilities, it's any of our patients with a neurological etiology that can cause spasticity. So patients with brain injuries, traumatic and non-traumatic, strokes, spinal cord injuries, multiple sclerosis, and other kind of hereditary hereditary neuromuscular diseases like hereditary spastic paraplegia. So but all of that can lead to a change in your functional ability, a change in gait, change in transfers, a change in being able to use your arm or leg functionally. So difficulty with care and hygiene. This is where we talk a lot about if spasticity is really contracting your arm down, it's going to be really hard to clean under your underarm to get into the axillary or the armpit area. And then same thing in the kind of peri area or the groin area. If you have really tight muscles and the legs are like super clenched together, it can be really hard to clean and get good hygiene care. But it can also affect how you're putting on clothes. If your arm is clamped down or if your legs are clamped together, it's gonna be really hard to kind of pull pants over things or pull, shirts on over your arms. So it can definitely cause some trouble with care. Other things we talk about is abnormal posturing. So if people have a dystonic neck, their head could be over to the side and they could get stuck that way, or it can affect their posture. So if they're, we think about it when babies are growing up, they have to get head control before they can get trunk control. So if you have an abnormal posture because of spasticity, then it can definitely affect how your trunk and your head control is too. So, and then contractures, this is where we talked about when, these muscles are super tight, they're tight for a long period of time, those muscles can actually shorten down and then turn into what we call contractures. And those are areas where you can't then straighten that limb out, or that it's kind of stuck in that specific posture. So we get concerned about that because the only way to deal with contractures, if they get to the point where it becomes permanent, is to do surgeries or some really drastic measures to try to open those contractures up. And then bone and joint deformities. So we definitely see this in our ankles. People have probably heard of Charcot foot for people with diabetes, and it's just abnormal or joint deformity around the ankle and foot, but that can happen because of spasticity as well. So some of the things that are causes of it, and one of the main things, like if just generally spasticity, it can be caused by the imbalance of signals. So those signals are coming from the peripheral and going into the central nervous system and going through the brain and the spinal cord. So anything that can affect a portion of the brain or the spinal cord that controls some of the voluntary movement can be subjected to develop spasticity. So when we talk about that, we talk about this reflex arc. So basically when a muscle is stretched, an impulse is generated, and that goes through and transmitted through a neuron in the spinal cord. And then as that neuron kind of synapses with what we call a motor neuron, it can transmit the impulse to contract the muscle. Once the muscle contracts, the antagonist, or the muscle that's against it, so basically let's say your knee is contracting, so you're bending your knee, then the muscle that straightens your knee will have to do what we call an inhibitory response to the spinal cord to say, okay, you've already bent your knee, now you have to straighten it out. But what happens in spasticity is that reflex response can be abnormal from either the inhibition standpoint or the constant reflex standpoint. So for example, so this schematic over here, basically, if you put your hand near a hot object, you're going to pull it back, you're going to jerk it back. Well, that's going to give sensory input in and through your spinal cord, if you can see my mouse and follow it. And then it goes in through, this is a spinal cord. Then it connects to a motor neuron, and that gives a signal to the motor to tell your biceps muscle, pull away, because you don't want to burn yourself. So that's a reflex. But what happens after that your reflex is, once you pull away, you have another sensory response that goes back in to the muscle, and it tells it, you know, you've moved, now you can relax because you're away from the danger. So but what can happen in brain injury and spinal cord injury is this can be altered in any portion. It can be altered right here at the spinal cord level. It can be altered at the brain level, because as you see, some of those responses kind of go up into the motor cortex of the brain. So if you have someone with a brain injury, a stroke, or you have spinal cord injury, anywhere along that pathway where there's a potential damage, it can create spasticity. So when I have patients in clinic, they're always asking me, when I'm calling out numbers or I'm talking to, you know, my colleagues or the residents or whoever, and I'm telling them, you know, this one's a 2, this is a 4, this is a 3. This is what I'm talking about. This is something called a modified Ashworth scale. So this is how I assess someone's spasticity. So when I'm looking at these different movements, I'm looking at how much am I getting a catch? Is it releasing? Is it then becoming more tonic? And that I can only range the muscle or the arm or the leg, you know, 50% of the time, and then I don't have tone, or more than 50% the entire movement, or is it completely rigid? So it's a scale from 0 to 4. It's called modified because this 1+ is the area that's not typical. So if you look at the regular Ashworth scale, it only had the 0 to 4, but then the modified Ashworth added this 1+. So, you know, these are very subjective tests. They're, you know, and that's why you want to have kind of the same person assessing you every time when you're talking about spasticity, so that that way they kind of get it in their brain. What is your tone like? And then when we do certain interventions, we can kind of compare it to what it was before the interventions. This is a very subjective scale, like I said, so it is very dependent on the rater. And it depends on how experienced they are with doing this scale. So it is something that we talk about a lot. And there are times where I'll have patients be like, well, Dr. So-and-so said that that was a 3, but you're saying it's a 2. And so there are discrepancies because it is depending on the rater and what they're feeling at the time. And it is also time dependent. It's what's happening at that moment. So somebody could have been a 3 2 weeks ago, and then I started them on a medicine and now they're a 2, or vice versa. You know, they were seen several years ago and they were a 3, or a 2 or a 1, and now they're a 3. So it can be affected that way as well. So some of the clinical things that we look at, and like I was talking about, you know, there's dystonias. So there's something called spastic dystonia, which is that tonic muscle, and there's overactivity of the muscle. There's the clonus, like I had talked about with the shaking. And then there's spasms, which people will say, well, I have spasms randomly. And those are kind of just sudden involuntary movements. It's like all of a sudden their muscle will contract. And then there's co-contractions, where there's abnormal contractions between the agonist and antagonist. So for example, your biceps muscle flexes your elbow and your triceps muscle extends your elbow. So if your biceps is super strong and contracting, but your triceps is trying to contract against it, there could be a co-contraction, and you could see that difference as well. So clinically, when I'm assessing patients with spasticity, I'm looking for all of these different things. But there are some benefits to spasticity. So some of the things that we talk about are, you know, do we treat everybody's spasticity? No, we don't treat everyone's spasticity, because some people are actually using their spasticity to do certain functions. So, you know, people that have a very weak limb, an arm or a leg, if they have spasticity, sometimes they can use that arm a little bit better because it gives them a little strength. And it could help with keeping muscle bulk. So, you know, if you have that muscle is constantly contracting, it's kind of like you're doing weightlifting, or you're doing something that's keeping that muscle bulk up. And then it can prevent DVTs or osteoporosis. And the reason we talk about that is because as your muscles squeeze, that blood is circulating. So it could prevent blood clots from happening. So that's what a DVT is. Or osteoporosis, because you're going to be able to do a little bit more weight bearing. You're able to get some of that good weight bearing through your bones. And so you can prevent that bone breakdown as well. So, and then when we talk about pressure ulcer formation, there's twofold. You can get pressure ulcers because of spasticity, because if you are tonically contracted in a way and you're kind of leaning on that, or you're putting pressure on that area. But you can also decrease the pressure ulcer formation, because if you do have tone, you're constantly moving. So you're not getting pressure in one specific area all the time. So we watch that as well when I'm watching people with spasticity. I'm like, is it functional for them? Is it useful for them? Why do I take away something that they're using to help them? So, but there's lots of complications too. And so, like I talked about before, difficulty with movement, abnormal postures, discomfort or pain, difficulty with sitting and transfers, hygiene, dressing. There's an increased risk for heterotopic ossification. So those that don't know what that is, heterotopic ossification is extra bone formation over a joint. Typically it happens with traumatic injuries. We just don't know why it happens, but we do know it's from immobility. So if someone has spasticity that's making them immobile, there's a potential that that bone could be forming there. So there's things though that can worsen or affect spasticity. So, you know, I have a lot of patients that have baclofen pumps, or we do Botox on, and they're like, well, Dr. Bavishi, I don't know what's going on. Is my pump causing me a problem because my spasticity is worsening? And I said, well, if they have no other, you know, like if there's no cause or there's nothing that has happened that I think that the pump is malfunctioning, we look at other things, and that we always rule all these other things out before I start saying, well, this is a result of aging with spasticity, or a result of your pump not working, or a result of you having, you know, not enough of a medication on board. So in that respect, you know, we want to make sure, is there pain under control? Are there any wounds that are potentially worsening it? Are there any infections? Any other stressors on the body? So even emotional stressors, which is something that people don't think about, but even emotional stressors can worsen spasticity. Urinary retention, constipation, fatigue. So I do have some patients that, you know, they're like, I'm fine in the morning, but by the end of the day, my spasticity is really kicking in. It's because they're tired, they're fatigued. Their body doesn't have the ability to kind of work against the spasticity and manage it when they're tired. So there's lots of treatments for it, and lots of treatments that have different side effects, and some are invasive and some are non-invasive. So we'll talk about them all, but non-pharmacologic, oral medications, injectables, and intrathecal. So from the non-pharmacologic, the number one thing I tell every patient is stretch. You cannot stretch too much. So stretching 3 times a day, it's very easy to do, correct? But at least stretching twice a day. Stretch first thing when you get up in the morning, stretch first thing when you go to bed. You know, if you can get an afternoon stretch in, perfect. But stretching really does help. It is actually the gold standard treatment if you read any of the textbooks for a non-pharmacological management. There are other things like functional electrical stim, serial casting, dynamic splinting. There is some case reports on acupuncture. There's not a lot though, and it's not 100% with acupuncture. We really only see, in my time of doing acupuncture, I've only really had maybe 3 or 4 patients that we even had success with acupuncture for spasticity, when I think of the hundreds of patients I've treated. And acupuncture is pay out of pocket. Most insurance companies don't cover it, and if they do, they only cover a small amount of sessions, like 10 to 20 sessions for the year. So acupuncture is a potential. It's something to try, but it's not a guarantee that it'll help. It doesn't have a ton of data behind it. And then massage therapy or massage really does help. But again, not all insurances cover massage. So it is a pay out of pocket, and it can get expensive after that, because massaging, it's a short-lived intervention. And so you need to have massages more often than you would think. So oral medications, I put all of the oral medications that I use, the top 3, baclofen, dantrolene, tizanidine, and diazepam, we use the most. And baclofin's usually our number one go-to. It's sedating at really high doses, but it's usually our first line. Dantrolene is the least sedating, and it's the oldest drug that we have, but it has a lot of liver toxicity potential. So we have to monitor liver tests. So we require, periodic blood work. So anytime I start someone on dantrolene, I check blood work every 4 to 6 weeks, every time I go up on the dose. And then once we have a steady state dose, I check blood work every 6 months for the rest of the time they're on dantrolene, because at any point in time, they could develop liver toxicity or a failure. They could be on the drug for 10 years and then all of a sudden develop liver toxicity. So we always have to watch it. Tizanidine is the most sedating out of all of them. And so we use it, but we use it, later on when we've failed the other two, or we have reasons why we can't do the other two. But tizanidine works really well for mainly spinal cord injury type spasticity. And it works really well for back pain. But the biggest issue with it is it can also affect the liver, not as bad as dantrolene, but we also have to use it. It can't be used with a certain antibiotics, and ciprofloxacin is one of them. So if those of you who may have urinary tract infections or frequent urinary tract infections, ciprofloxacin is a go-to medication. And so it's difficult if you have that and then you're on ciprofloxacin quite often, you can't be on tizanidine. And then we use Valium quite a bit, but we use it only as an adjunct to baclofen. Again, very sedating, and it can cause drug dependence. So it's lower on my list. Gabapentin, it has some efficacy, but more for the pain. So if there's, spasticity related pain, then I would use gabapentin. But again, it can be sedating. And so we use it more if some of the other meds aren't effective. And Artane is one that's for dystonia. We use it more in pediatrics and our cerebral palsy kiddos. But I do have some adults on it if we have run out of other options when it comes to oral medications. So botulinum toxin. So Botox, we all hear about cosmetic Botox for face and wrinkles and, all of that. And so it's the same drug that we use for spasticity that we use for cosmetic purposes. The brands are 3 different: Botox, Dysport, and Xeomin are both botulinum toxin A. Myoblock is botulinum toxin B. So we use them for focal muscle management. So for example, if I have someone on baclofen, and they're loose everywhere, but then they're like, well, my hand and my fingers are tight, then I will do Botox just for their hand and their fingers instead of increasing the oral baclofen, because we usually use the botulinum toxin to target specific muscles, because there's a limit as to how much toxin you can use. Again, botulinum toxin is the same toxin that you hear from if someone has botulism. So it is a toxin that we're injecting. Over time, people can develop antibodies to it as well. So we watch the use of it. We don't want to overuse it as well, but we have some patients where, we use it for a certain amount of time, and as they heal, then we don't need it anymore. And there's some people that I've been doing Botox on for years. So it's really, we don't have an answer as to who's going to have a reversal of their spasticity as they improve from their brain injuries. So some of the things that I don't use, so there are some contraindications to using it. So obviously hypersensitivity. We're not going to use any drug that people have hypersensitivity to. But there's ongoing infection or they're on antibiotics. So there's some antibiotics that can interact with the botulinum toxin. And so it depends on the antibiotic, but in general, no antibiotics for 48 to 72 hours before a botulinum toxin injection. Because if you think about it, it is a toxin we're pulling from a bacteria, and antibiotics are trying to kill bacteria. So there's a potential the antibiotic could affect the toxin and the efficacy of the toxin. And then the other thing is if someone has contractures and we've been doing Botox, the orthopedic surgeons will not want us to do Botox within a certain time frame before. So if you have had Botox, then the orthopedic surgeons won't do any surgery for contractures until you're 90 days out from your last injection, because they want the Botox to be completely out of your system. If you think about it, it makes sense. If you're too loose at the time that you go for surgery, they're not going to release your contracture enough. And then after that, you're going to come back and be like, doctor, whoever, did my surgery didn't really do a great job because I'm still have my contracture, and the answer is it could be because you were already too loose because we did Botox too close to it. And then after the tendon lengthening procedures, we don't do Botox for at least 90 days because you have a healing period. Sometimes you're in a cast and other types of bracing. And so I will not do Botox until after they're released by the orthopedic surgeon to do more Botox. Fear of needles, I do have quite a few patients that have a fear of needles. We still do their Botox, but we do different techniques to help them with their fear of needles. And then respiratory depression. So, if they have any respiratory issues, we can still do Botox, but if they're having oxygen's low, they're having trouble breathing, we're not going to do Botox because it can, if it does spread, the toxin does spread, it's going to make that worse. And then there's two things that we can't do Botox within 90 days of the last injection for two reasons. One is there's a potential development of antibodies if you do Botox too soon. Two is insurance companies won't pay for it unless you're at least 91 days from your last injection. So some of the things to consider if and when you're getting Botox, if it doesn't work, doesn't mean it won't work. It could be dose dependent, it could be injector dependent, it could be which kind of Botox they're using. It could be for cervical dystonia, if we're using it for your neck, there could be swallowing trouble and trouble with voicing as a result of it, because if you think all these muscles are awfully close to where the muscles are for swallowing, and as well so the voice box for your phonation. So but then the other thing with cervical dystonia is it could take multiple injections to figure out the correct pattern. So it could be a trial and error thing as well with cervical dystonia. But not all muscles need to be injected. So like I said, consider patients' gait patterns, their seating and positioning, their transfers, evaluate which muscles are most affecting the function, and only use the Botox there. So there are some recent studies, and I thought this was really interesting, and I thought I'd bring this out to everyone, that they were looking at functional MRI after people were getting Botox injections, and they were showing that, there's a potential of changes in the cortical orientation with Botox injections and after you've been doing it for a while. So it could be the reason why some patients don't need ongoing injections, because the Botox is actually helping them be able to be more functional with their limb or wherever we're Botoxing, and then it's in turn going up to the brain, and the brain is reorganizing. So there is some really cool studies that are coming out to show that. And so that might be something that we consider for post-stroke recovery. At least that's where a lot of the studies are coming out, is that we might want to do Botox a lot earlier on than we originally thought. So there's some other clinical studies that they're doing, about Botox and potentially affecting some of the neurochemical levels, some of the cortical reorganization, like I talked about. Those are still ongoing, so we don't have a lot of data behind that, but those are just some really interesting things that are going on with research on Botox. So phenol is one area. Not a lot of practitioners do it. We have two of us that do it at OSU, but that's really, you're actually trying to burn the nerve, basically. So I only will do it if there's a large group of muscles that are affected, that's affected by one nerve. And it can last for up to 6 months. It's actually super cheap. So it's much cheaper than Botox. So it is something to consider, but it actually is something we also don't enter into lightly, because it can cause side effects of pain. It can cause weakness. And so there could be some difficulty too with the injection, because you really have to try to get right on top of that nerve. So there's some newer techniques coming out with ultrasound guidance, and they're really helping. But at the same time, with the phenol, you have to be very concerned about some of that. So intrathecal baclofen, this is an implanted device that goes into the abdomen, and there's a catheter that goes into the spine. and it's actually for targeted drug delivery. So it actually puts the baclofen in a liquid form and directly into the spine. It requires only a small dose of baclofen to exert its effects. It's on the microgram level, whereas the pills are on the milligram level. But it does have its risks because it is an implanted device. So this is what it looks like. This is the actual device. It's not as small as you think it is. It's like the size of a hockey puck. And it goes, like I said, into the abdomen. There's a catheter that goes around the spine, and then they thread the catheter up. It's implanted at OSU. It's implanted by a neurosurgeon. Other locations across the state could be implanted by anesthesiologists, could be implanted by pulmonary physicians. So it really is, you know, the training of the person that's doing it. At OSU, we have our neurosurgeons placing these pumps. But it is something that, you know, has to be refilled. We have to refill it through an injection. We also have to titrate up the dose. We have to, then there's a list of potential side effects. So how do I select patients for baclofen? Multiple criteria. One of the biggest ones is if they're sedated on higher doses of oral baclofen, if they've failed management of spasticity with multiple agents, if they have non-focal spasticity. So if they have pretty global spasticity, both arms, both legs, or an entire arm and leg, and it's too much for medications to manage or for Botox to manage. And they have to be very medically stable and infection-free. And wounds should all be healed because of where the pump and the catheter goes in. You don't want any wounds near those areas that could potentially get infected, because immediately that bacteria is going to go to the implanted device and infect it. And since that catheter goes right into the spine, it connects to your cerebral spinal fluid, and people can get infections into their spine. So I have a bunch of exclusion criteria. So there's a lot of people that we don't use baclofen pumps for. If they have ongoing infections, if they have a really hypersensitivity to any baclofen, if they have a body habitus that we can't implant the pump successfully and be able to access it for refills. And then if they are underweight as well, that they don't have enough, you know, pump bulk or weight to house the pump. For TBIs, we say don't do it less than 1 year post-injury. And the reason why is because patients with traumatic brain injuries are drastically changing over the first year. And I don't want to put in a pump in somebody that a year later may not need it at all. So you're subjecting them to a surgery. Now, there is some data for patients that are in a lower level of consciousness that if we implant a pump sooner, it might help with storming and other things. So there are some patients, select patients, that will do it in traumatic brain injury if they're less than a year post-injury. Or if people are tolerating oral therapy, why am I going to put a pump in you, you know? Or if there's any spinal anomalies, so if they have scoliosis or if they have hardware that makes it difficult for the catheter to be placed, and any social or behavioral things, because it is a device, because it requires refills. If there's anything that they have trouble with transportation, getting to appointments, getting their refills done on time, then we get concerned about them going into withdrawals of the baclofen. We've also had people try to self-inject through the pump as well. So we really watch for some of those as well. What you can and can't do with a pump though, you can get an MRI, you can travel and fly, you can exercise, you can do electrical stim, you can do ultrasound, you can do a lot of things. People, you know, I recently had a patient that was like, I don't want a pump because I want to go camping, or I want to go hiking, I want to do all this stuff. I'm like, but you can go out and do all of that stuff. As long as you come back in time for your refill, you can go out and do whatever you want. But you can't do hot tubs. It is a metal device, so nothing that's over 99 degrees. Any strong magnetic device needs to be at least 12 to 24 inches from the pump. So the new iPhone 13s, actually, we've had a lot of data that if they're in the pocket or they're near someone's baclofen pump, it can shut off the pump. Because of the type of magnet that's in the iPhone 13. So if you have a newer smartphone, be a little wary about which pocket you put it in. Any twisting exercises, anything like shortwave diathermy, that's basically doing a lot of heating near the pump. You don't want to heat anything. And so we're not sure if there's any effects for pregnant women or nursing mothers because it is intrathecal. So far, there's been no data that shows that. So people could successfully have an intrathecal pump and still have children. But there's lots of complications. And so when we talk about baclofen withdrawal or there's baclofen overdose, baclofen withdrawal is thinking about anybody with drug withdrawal and how they itch, they're agitated, they can hallucinate, they can have seizures. Baclofen overdose, sedation, respiratory depression, seizures, coma, they're really medical emergencies. So if you have a baclofen pump, you hear an alarm, or you feel anything that's one of these two, you're coming to the ED. So they aren't without their complications. They are a mechanical device. The battery can fail. You know, the catheters can break. There are things that are potentials, but when they work beautifully. So some of the things, just to kind of wrap up, things that I consider for spasticity treatment, you know, are patients using their tone for mobility? Is the tone affecting their mobility? Time to efficacy and onset of the medications. So medications usually 30 minutes and most last 6 to 8 hours. Botulinum toxin takes 7 to 14 days to be effective after the injections, can last up to 90 days. Intrathecal baclofen, 24 hours after a pump is adjusted and within 1 or 2 hours after a test bolus, you can have effectiveness. You want to look at responses to dose changes in medications, long-term effects, and intensity of the treatment needs after whatever interventions, so serial casting, dynamic splinting, functional electrical stim, and access to care. And this is a really real thing. There are not a lot of practitioners that manage spasticity in a global way that it can be accessed in smaller hospital systems or smaller towns. So there's a really real concern for access to care if people have spasticity. So I always do goal setting with my patients. We kind of tailor it to an individual basis. I ask the patients, well, what do you hope to gain from this? What is your thoughts? What do you want? Do you want symptom relief? Do you just want functional improvement? Do you want, you know, enhanced service activities? Do you want hygiene, caregiver burden? A lot of caregivers will be like, they're so tight, I can't get them dressed, I can't get them moved, I can't get them in a chair. So we start talking about, you know, what are the goals of managing spasticity? So that's all I have. And I'm not sure if there were questions in the chat as we were going along, but I will take.
We didn't have any questions yet, but that was really comprehensive. Presentation. So thank you so much for getting into all that detail. So if you have questions, you are welcome to use your raise hand button. I can't always tell the difference between the raise hand button and the clapping buttons. You'll have to give me a second there. You can also put stuff into the chat, and I'm happy to read that out as well. You can do it publicly. You can do it just to me. That's fine too. So while you're thinking of questions, and I don't see any raised hands yet, I'm just going to ask a couple things. Sheital, the last time we talked about this, when we were planning it, I mean, I learned so much about spasticity and just sort of the range of things, but also sort of some of the time course. But it strikes me as, just how do we catch it, right? Because if it doesn't happen right away, but you got to catch it early, being vigilant seems to be pretty important. So how do I know that this is spasticity? Like these symptoms might be spasticity, or could they be something else? Like what if I'm out of shape? Or what if I'm feeling particularly stressed? Maybe it's another musculoskeletal injury that cropped up. How do you sort that all out? And what would you tell, a patient or a caregiver, in terms of trying to figure out what to do next?
Yeah, so you look at timeline. Timeline's one of the big things and what it actually is. So like when we talk about velocity dependent, right? So the quicker you move, is it kicking in some more? So that's more spasticity. Are you having some of those other like movements? Like when you go to pick something up, or is your arm jerking, or are you having a clonus where, your hand or your ankle is beating really fast? Like those would be more spasticity potentially. If you're just having like a tight muscle because you're hunched over a computer all day long on Zoom, that's more not spasticity. That's more your tight muscles from, stress, tension, your posture, and how you're doing it. So really kind of looking at that. Plus you have to look at neurological injuries too. Do you have a neurological injury? If you don't have a neurological injury, more than likely it's not spasticity, because spasticity is definitely brought on by some kind of a neurological injury, whether it is a neuromuscular disorder that you have, genetics or heredity, or some kind of, neuromuscular problem, or whether it's from a traumatic injury like a spinal cord injury, brain injury, or an acquired brain injury like a anoxic or a stroke. So any of those, it's really looking at the history, looking at the time frame, looking at how its onset is, then also looking at how it's affecting your function. So that's the other part. Like, if you're starting to notice, hey, I'm laying down, and as soon as I go from like sitting to laying down, my muscles all spasm and jerk. If it goes away, then it's more than likely just the fact that your muscles tightened up for a little bit and they relax. But if you transfer and you lay down, and then all of a sudden you have this dystonic or spasm, and then everything starts shaking, and it doesn't go away for a little while. You really have to stretch. You have to move your leg in a particular way to make it stop. Then there are concerns with that. And I think Jordan is putting on there, but yes, spasticity can actually affect your speech. So people do always consider it in the context of limbs and trunk and neck, but you can have something called spastic dysarthria, where it can really affect the way you speak too. And you think about it, you've got muscles everywhere. So the real thing for you is to look at the history, what your personal history is, the time frame for which it's coming on, how is it affecting function, and then looking at, are there things that make it better or worse? If stretching makes it better, then it could be, spasticity. But typically, if you don't have, if you have more like a sprain or a strain, you're going to have pain and other things with it. It's going to be pretty acute, and you're going to have some knowledge of some kind of traumatic event with it. So really kind of gauging it that way. And it's hard. And sometimes if you can't figure it out, that's when you call your doctor and you say, hey, I'm having this. They assess you. And they're like, yeah, this is not just a sprain or a strain. And they may send you to a PM&R doctor like myself, and we can assess it. So, really kind of, if it's starting to affect your function, you definitely want to get in to see somebody.
All right. So you mentioned a couple things in there. I had some follow-up questions. So clearly there's a lot of different conditions that you might want to, consider this for. Are there specific conditions with spasticity that can lead to spasticity? Very hard word for me to say, by the way. That can be particularly problematic, or maybe it's harder to catch in those situations. Like, what would be like, if you've got X condition, this is something to really be thinking about. Are there any in particular?
Not really. I mean, so like, we talk about people with multiple sclerosis. So, it's a difficult one to diagnose, but sometimes people can have early onset and not really know it's multiple sclerosis because they have a spasm or they have something, and spasticity could be a part of it. And then it goes away after a few days or a week. And they have these kind of random events that happen periodically. And then they're like finally going to a neurologist because it's getting worse. And then they realize they have multiple sclerosis. So that's one of the diagnoses that's always been difficult to diagnose because it's happened so sporadically. But when you think about, TBI, ABI, stroke, spinal cord injury, it's pretty obvious when that spasticity starts coming out. And it's much worse. I think the worst out of all of those is anoxic brain injury. So if someone has an anoxic brain injury, I always tell everyone number 1, 2, and 3 on the list is spasticity, spasticity, spasticity. So that is the worst thing that can happen with anoxic brain injury, but it also talks about prognostication. So if someone with an anoxic brain injury has spasticity come out early on, they have a better prognostication. So, but it is, it is definitely something that you see more prevalent with anoxic brain injury. And for strokes, it happens in the continuum. So initially when people have flaccidity, then they can have something we call emerging tone, where they're starting to get some signals, but it's not causing them functional trouble. And then sometimes that emerging tone after stroke can actually lead to functional improvement and strength, but sometimes it can lead to spasticity. So that's the one where we're always hedging when someone has an early stroke and they're getting this tone. Is it the emerging tone that's coming out that they're going to get function in that limb, or is it emerging spasticity that's coming out? And we won't really know that until we do more therapies, until we get further down the road. And sometimes that tone, that emerging tone, the therapist, and you'll learn about that next week, the therapist will use that to their advantage to help people with their recovery.
Great, thank you. So again, if you have any questions, you're welcome to raise your hand and we can call on you as we go. You know me, I've got tons of questions. I definitely want to make sure we get to yours. Okay. So one thing I'm thinking about is, there's just a lot of questions that you have to think about, right? It was really interesting to think about, just how do you manage it? What are you looking for? What kinds of information do you need? And I think it was really helpful in talking about, what to observe in your life in terms of just thinking about, do I have this? How's it going? And so just sort of how to observe, I think was also helpful. What about the care side of it? Is it pretty standard type of care out there for spasticity management? Or is it not well trained? I guess what I'm asking is, like, should we be shopping around? What do I want to look for as a consumer in the doctors that are managing my spasticity?
So I think one of the things I mentioned was experience. So one of the things that we talk about is, for physiatrists or physical medicine rehab doctors, when we're trained in residency, we have to do a certain amount of Botox and backlift and pump management injections to even graduate residency. So we already have that training. But then, as they graduate, people may not have that in their practice. So really looking at, who is doing that in their practice. When we start thinking about neurology, neurologists aren't always trained in like injections, but they can be trained in some of the medications to manage spasticity, like backlift and pumps and the oral medications. But not all neurologists through their residency training or any of their training are even taught botulinum toxin injections. Also looking at, what, if other people that have gone to specific physicians, but, where are those physicians located too? Because that's a tough one. When you need injections every 3 months, you don't want to be driving 3 hours to find the physician. So location matters too. But the number one thing is, their experience in doing the injections. Even if they graduated a year out, they still have experience because they've done it during their residency. But, if they even advertise that they do it. Now, there are different things when I start talking about backlift and pumps that, I have different biases too, and I'm not going to bring all of those biases out, but really thinking about who is managing that backlift and pump, and are they managing it based on function? Are they looking at your function? I always say, like, there's functional neurologists, there's functional neurosurgeons, and then there's PM&R doctors. We all focus on function. So looking at somebody that's going to focus on function, because that's what these treatments are all about. They're helping to improve people's function. So, that's the main thing. Is so if you're with a physician or nurse practitioner or whoever that's just saying, well, are you tight or are you loose? But they're not asking you, how's your function? Are you walking better? Are you doing this better? Or are these affecting you somehow? Or how much is your tone affecting your sleep, your walking, and all that stuff? that's what you're really thinking about, because that's what you want your practitioner to be doing, is really focusing on your function and then tailoring your therapy to your function.
Okay. I just point out that you got a shout out there in the chat.
Oh, hi, Liam.
Okay, so two last questions that I've got. So what advice do you have for family members or family caregivers, when you have someone in your family who has spasticity?
So the number one thing is, as a caregiver, what is this spasticity doing for the patient, or your loved one? Like, is it affecting them sleeping? Is it affecting them being able to be independent? Is it affecting them to be able to bathe or dress themselves safely? Those are the things as a caregiver you want to look at. And, or, as a caregiver, if you are total care for someone with spasticity, for example, if someone is, wheelchair dependent, or they need full assistance with all of their activities of daily living, how easy is that for you, as a caregiver? Is it difficult? Are you really pulling against limbs? Are you really trying to, pick someone up and try to transfer them? Are they not fitting in the Hoyer? Are they not being able to manage in their bed? Are they up all night screaming and crying because they can't get comfortable? So as a caregiver, looking at some of those things for your loved one or the person you're caring for, and how it's affecting what you're trying to do for them.
It's a good point. It's a good point. And then the last question I've got here, kind of an open-ended one. What are open questions in spasticity? Just thinking about where the research is going, or things that we don't know that we want to know. What are those unknowns that we're going to come across as patients or advocates that we should be prepared for?
So like I was talking about, for botulinum toxin especially, is it causing cortical reorganization? We're getting some data with functional MRI. I just had recently someone tell me or ask me, well, is the Botox going to make my muscles waste away and make them super thin? So there's some of those questions that are still open-ended questions, because we don't have the data. So the research is really going on that. Plus, there's this whole 90-day thing. The study that was done on that was 30 years ago, to say that there's a potential that people will develop antibodies to Botox injections if they do them more often than every 90 days. That was a research study with a small grouping of people, but it's what we have. So more research on botulinum toxin, and are people actually developing antibodies to it? Can we inject them sooner than 90 days? And so other things too, they're talking about medications. Like you saw, we have a list of medicines, but they're all with a list of side effects. They have a lot of sedation. There's not like a lot of tools in my tool chest, because if someone fails baclofen, tizanidine, or dantrolene, I'm kind of done with medicines, because Valium and gabapentin and Artane don't really have as much efficacy as those three do. So we are really kind of limited with some of the things we can do from an oral medication. Other things that are really neat that are coming out, are things that you'll learn about with the therapist next week, or the functional electrical stim, some of the different types of splinting and bracing that are out there. There's so many potential therapeutic interventions, and then being able to try to get them for patients at home. So, those are some of the areas that are evolving as we get more and more technology out there. There's also, looking at technology on using, brain stimulation to help with some of this as well. Now that is very, very, very early on in its studies, but those are some of the open-ended questions that we have for spasticity. And then we also have questions like, why do some patients, it all of a sudden reverses? We don't know. Like, why do I have some patients where I have to give them Botox for the rest of their lives? And I have some patients where I do like 4 or 5 rounds of Botox, and then they're like, it's lasting longer and longer every time. And then I don't have to do their Botox. So it's like, we don't really have those answers. But and those are some of the areas of research, is how do we select that patient population? How do we pre-select for that? And we don't have that answers yet.
Okay, good to know. All right, everybody, we're almost to our time. So I will just say thank you so much to Dr. Bavishi for an excellent presentation. Great answers to these questions. It's just a wealth of knowledge. And so I very much appreciate that. So next week, like we were talking about just a little bit, we're going to have our second round of this session. And so we're going to have some therapists talk us a little bit more about, like, what does the therapy look like? What do you have available to you in the clinic, as well as what might be available for you to try at home. And so we'll get into some of that. So we'll be back here next week on the 8th at 6:30. Until then, I hope you have a great rest of your night and a great week, and see you soon. Thanks again. Bye, everybody.
Thank you all.